cervical spine. So I'm just gonna go, you guys can review this kind of stuff for me. Landmarks, if you're not sick of me saying review your landmarks, then we'll do it again. You guys know these terms by now, kyphosis, lordosis, depending on the curve of the spine. The kyphosis is the humpback, lordosis is that lordotic curve in the lower back. Okay. C-spines. So prior to doing a C-spine exam, I would watch out for some things that can cause artifacts or issues. If your patient has earrings, necklaces, hair ties, even if they don't have metal on them, bobby pins, if the patient has dreadlocks, braids, or wet hair, ask them if they could tie it up on the top of their head. If they can kind of get it up and out of the way, then you won't have the artifact, especially for the lateral APs and obliques. It will really show, or lateral AP and odontoid, the obliques, you can usually kind of get it out of the way. Ask the patient if they have false teeth or a partial. If it can be removed, you can take it out. Please give them something to put it on. If they have a collared shirt, those can sometimes show up as an artifact as well. So earrings and necklaces, check your C-collar patients. Just because they come through the ER with a C-collar on doesn't mean that whoever brought them in took their earrings and necklaces off. So always double check. Dentures, the bra straps with clips, slide those down their shoulders. The dress shirt collars, a beaded neckline. If your elderly female patient has a beautiful blouse on and it's got a lot of beads around the neck, that's going to show. Tongue ring doesn't usually get in the way unless it's for the odontoid or the open mouth, OPM, that's what that's for. They can actually stick their tongue out pretty far, and you can still get it. Hair ties, even without the metal, they will show. Bobby pins and wigs, just be sensitive to your patients that might have those on. They might be uncomfortable to take it off, but they all show. Braids, with or without beads, or dreadlocks and wet hair will cause an artifact on your C-spine images. So for us, routine-wise and comp-wise, you need the 5-view C-spine, so you need to do a lateral, both obliques, AP and odontoid. If your patient needs a swimmers, you'll have to do that too. Trauma C-spine in the ER is going to be only 3 views, so you're going to do a lateral. If your patient is in a C-collar, that'll be a cross-table lateral. In AP and odontoid, watch your orders on your outpatients, because if they are post-fusion, the doctor might want an AP and lateral only. There might be a flexion extension request. Those can be by themselves. They might just ask for the flexion extension only, or they want a 3-view series with a flexion extension, so it's actually a 5-view series, or it could even be the 5-view with flexion extension, so it might be 7. So just watch for that. Laterals and obliques are done at 72 inches for your series. The other views are done at 40. If you can't see C7, T1, you're going to do a swimmer's view. We do them at 40 inches. That is not what your textbook has listed, but that's what we do at our facility. So, non-trauma, lateral position, the patient is going to be standing. Most of us do a left lateral, left shoulder against the wall bucky. Try and get them to relax their shoulders as much as they can. You're going to kind of want to jut their chin forward a little bit. It brings this away from the C-spine. I put the top of my light just above the ear. SID is 72 inches. Why is it 72 inches? Because look what we have here between the patient and the wall bucky. We've got OID. So remember, anytime we have this sort of space here, we tend to move to 72 inches to compensate. Your textbook breathing is on expiration at the clinical site. We just have them hold respiration. It's a 10 by 12 cassette. I would prefer you guys to use your 15% rule here for technique. So 12.5 at 96 as an example. If they have real big shoulders, this might be a 16 mass. Some of your techs do not use the 15% rule, so they might be using, say, a 20 mass at 80 kVp. The 90 range kVp gives you better penetrability. Anytime you increase your kVp by 15%, you can drop your mass. Dropping your mass drops your patient dose. So please go with that. What does your lateral C-spine look like? You need to have C1 through C7. You have to demonstrate at least the top of T1. You want to count from skull down. Ideally, the ramus of the mandible is not superimposing over your cervical spine if you kind of jutted the chin out a little bit. Lateral C-spine visualizes the zygapophyseal joints. It does not visualize the circles, the intervertebral foramina, like the lateral lumbar and the lateral thoracic spine. So make sure you have that in your notes, that the lateral C-spine is different. Lateral C-spine, you're looking for the Z's. Okay? The zygapophyseal joints here, these spaces, that's what you're looking for. Anatomy. Trauma lateral. So if they are in a C-collar on a stretcher and you need to get a lateral cervical spine, this picture is showing you that this picture is showing you a cassette right next to the patient. What we would use is the wall stand. So the Bucky wall stand. Essentially, it's the exact same thing as if they were standing up. You're still 72 inches. You're going to be up against the wall stand. You're going to center in the same location. Top of your light right above the ear. Still centering the same place. Same idea. All right? Trauma lateral, you might see artifacts from the C-collar. There's not much you can do about that. Why would you use the 15% rule? Why would I use 12 at 90 versus 20 at 80? The higher KBP gets me better penetration of the part. I can usually visualize between the shoulders better. Lower MAS, less patient dose. Anytime you use higher KBP, it's less patient skin dose. So the 15% rule, right? To compensate, if you increase your KBP by 15, you want to half your original mass. Okay, you're going to do 2 obliques. We use posterior obliques at our clinical site, and they are 45-degree obliques. You're still going to be at 72 inches. You're going to use a 15-degree cephalad angle. His head is really tilted too far over. Don't kind of rotate the chin that far over, and I'll show you in lab a little bit better. But so 45 degrees, you're still centering the C4, 72 inches, and 15-degree cephalad angle. Right. This is an example here. See how her head is not rotated so far over? This is more what you'll look like. And you're coming right down the neck here, right to C4, and see these nice open circles here, the intervertebral foramina. That is what you want to see all the way down if you're positioned correctly. Your textbook gives you options for obliques. You can either do a posterior oblique or an anterior oblique. What you need to remember is you have to use a different angle direction. For the posterior obliques, which we use at our site, we use 15 cephalad. If you get a textbook question or a board question on anterior obliques, it's 15 caudad. So you're going to reverse, okay? Just watch for that. What do you want to see? You want to see these nice open circles here, the intervertebral foramina. One thing you do need to know for boards, most likely, is what you see on anterior obliques versus posterior obliques as far as the foramina goes. So anterior obliques, you see the side closest to the IR. Posterior obliques, you see the side farthest. So get that on a flashcard somewhere. Anatomy. Just demonstrating more anatomy for you. So you can see why we see certain things at 90 degrees or certain things at 45 degrees. The foramina for the cervical spine are at the 45-degree oblique, and zygapophyseals are in true lateral. Apiaxial, so this can be done either standing or laying down. Same cephalad angle, 15 to 20 degrees cephalad. Same central ray, still at C4. You're going to raise the patient's chin up a bit. We're moved into 40 inches for this one, down to an 8x10. Hold their breath. Ideally, you want to see the chin up and out of the way if you've angled up high enough. So here we can see anterior. The AP open mouth, or some people call it the odontoid shot. So you want to line up the upper incisors and the base of the skull. You're going to center right through their mouth. still at 40 inches. Try and keep the patient's mouth open during exposure, so you might have to work quickly on that. You want to be able to see the lateral mass on both sides, which are these squares here. The zygapophyseal joint space between C1 and C2 are your open spaces here. The dens, or the odontoid process, you want to see clearly out of the way of the teeth and the base of the skull. So this is the teeth right here, these two squares. And you're trying to see if that's lined up. This is a beautiful picture here. Nice lateral masses, zygapophyseal and odontoid process, clear of superimposition of the teeth. The teeth are right up here. Swimmers. The swimmer's view or twining method we'll use if we can't see C7, T1 space. Textbook for swimmers is centering to T1. We do not use this at clinical. We stick to the same C4, C5 level. Our radiologists want to be able to see C1 to count down and verify numbers. But textbook, you need to know that for board. So textbook swimmers is central right at T1. SID of 60 to 72. All right, watch for that. So you're raising the arm closest to the image receptor, dropping the opposite arm to kind of get a better visual of C5 to T3. You may need to angle down, or you may need to lay the patient down. You can do it standing or laying down. If they have a real big shoulder or they can't drop this shoulder down to their toes, you can add a 5 to 7 degree cephalad angle here and get through the space.